Our first speaker will be Stephen Verderber, who is well known to many from the University of Toronto, and he is a true transdisciplinarian in the field of design and health. Over to Stephen.
Okay, it's a real pleasure to be here. Thank you. And as we start, this is a presentation of work that a doctoral student of mine did, Shan Jiang, who just finished her PhD at Clemson University, where I had taught for 6 years. And I've been at the University of Toronto the last 2 years, where I'm the Associate Dean for Research, and I have a cross appointment in the School of Public Health at the University of Toronto. And Shan, unfortunately, couldn't be here today because she was married recently, and she regrets not being here. She's a graduate of Tongji University, and she's born and raised on the China mainland. And her degree is in landscape architecture from there. And so what she wanted to do in her dissertation was, and we worked together on this, I was her advisor, she became captivated with this concept from a book I published in 2010 called Innovations in Hospital Architecture, which was the second book in a series that I'm doing for Rutledge in London that will eventually have 5 books in it. The first book was Innovations in Hospice Architecture. The second was Innovations in Hospital Architecture. The third one's coming out in October, Innovations in Transportable Healthcare Architecture, which will deal with disaster response globally and what we're not doing, what we need to do as architects and others to respond to climate change and its ramifications for our professions. And then there'll be probably 2 more books after that, we'll see, because they've asked for a total of 5 in this series. And anyway, so she became captivated with this idea from the second Innovations book, a concept in the 4th chapter called theraserialization. Theraserialization is a term that I coined a few years ago to respond to the rigidity of the relationship between the interior healthcare environment and the exterior environment. In other words, it's a call for transparency and for serialization of space from the exterior to the interior and vice versa, and breaking down the visual and physical barriers between landscape architecture and architecture, which continue to stymie progress in this area in terms of salutogenic design in the built environment. Because, and I can maybe refer to this a little bit later when we have our Q&A about the problems of academia and how we can't really advance in a professional context unless we can advance what's going on at the university level. So anyway, so she became interested in this idea of theraserialization, and she wanted to operationalize it in an experimental context. So first of all, she conducted this, she did this extensive literature review, and she published it as a chapter in an article in the journal based in the China mainland called Frontiers of Architectural Research, which has been out only 3 or 4 years. So she published a literature review. But some of these key articles pertain to, she articulated 12 design considerations that she generated as hypotheses that would guide her dissertation research. And so they're shown here, the 12 are shown in relationship in this chart relative to some of the key articles of the more than 100 that she found, that she summarized in this literature review. And they cover many of the work that many articles that a number of you know of from evidence-based research that's been published in the literature in the last 20 years or so. But due to time, I had these 12 guidelines that became hypotheses for her investigation. The first was hierarchy of landscape realms. And I'll talk about these more in a few more minutes after I discuss this empirical study. The second guideline is called courtyards that breathe. The third is vertical gardens and cutouts. The fourth is positive outdoor spaces. The fifth is micro landscapes that occur along narrow wings within a hospital environment. The sixth is cascading roof terraces. The seventh is transparent arteries. The seventh is landscaped arrival zones. The ninth is about dematerialized edges. The 10th guideline is atrium gardens and light wells. The 11th is sequestered gardens, and the 12th and final one is therapeutic viewing places. Now, these came from the literature. There are built examples that are cited, but many of these concepts have been discussed over the last few days, of course. And so they're familiar, but they might not have been framed in the same way in terms of this lexicon of terms. So what she did, she developed an empirical investigation where she had, let me see, where do I have this? Her experiment was done in a laboratory setting at Clemson University with 48 undergraduate male students and 47 females. And they studied, and by the way, the details, I obviously don't have time to go into great detail, and there are no statistical charts showing the regression analyses or alpha chromebacks or the standard deviations and all that. She's going to publish an article on the actual experiment itself in a forthcoming issue of the Health Environments Research and Design Journal, which some of you might know as HERD, which is based in the United States. So I'm sort of glossing over some of that, but so what she did was she developed through a jury, a panel, 21 slides that depicted 3 different conditions. Conditions that were highly transparent, 7 slides, 7 more that were moderately transparent, and 3 that were quite opaque, which in other words, and she focused on the waiting room environment in the hospital setting because she reasoned that this notion of theraserialization, if she was going to operationalize it or really test it to see if it's valid empirically, that would be a good place to do it because virtually everybody who enters a hospital environment enters the waiting room, the main arrival sequence, and before proceeding to any of the other departments. And so that's what when she worked with these research subjects in the experiment, they were told that these were settings for waiting rooms. And so she studied this through a variety of techniques that dealt with, she studied heart rate. She measured physiological responses to these images that were presented, these 21 images, in three stages, stage 1, stage 2, and stage 3. She measured each respondent's systolic blood pressure, their heart rate, through a device called a GE Dynamap recording device, and she assessed their mood disturbance levels through a pre-validated tool called POMS, P-O-M-S, that some of you might be familiar with. So she had 3 ways of recording responses, and the 4th way, she asked them to evaluate each of the 21 slides on a 5-point rating scale, a satisfaction or preference scale. So the preference data, and so there are a whole series of intercorrelations between the different types of data that she collected that are the basis of her dissertation. But here, this chart shows, she subjected the satisfaction data, the preference data that were rated on the scales to what's called nonvariate multi-dimensional scaling, which yielded a series of 6 factors. It's called factor analysis. It's a multivariate technique in statistics that's been used in environmental psychology and environmental design research for 30 years. And of the 6 factors, 3 of them were found to be particularly germane to 5 of the design considerations that I just outlined to you. And so on this left side of the chart, these are factor 2, factor 4, and factor 5. Factor 2 is, she titled Transparency with Meaningful Views of Nature. Factor 4 is titled Limited Views of Nature with the Presence of Indoor Plants and Fireplaces. And factor 5 is Transparency with Meaningful Views of Nature and Abundant Natural Daylight. And so it was connected to these, in terms of these hypotheses, these 5 of the 12. Transparent arteries, dematerialized edges, the atrium gardens and light wells and sequestered gardens, and therapeutic viewing places. And so that I'll focus on the ones that, and of these 5 that are shown in this chart, she sees these as the 5 as the sort of the validation of this notion of theraserialization. In other words, they're empirically connected to these five. And this is just a larger view of the hierarchy of landscape realms, which I'll summarize real briefly here. And the building that's cited is the Miami Valley Hospital in Dayton, Ohio, which is designed by MBBJ and opened 2 years ago. The second is Courtyards That Breathe, and the example she cited here is the Center for Spinal Cord and Brain Injuries in Basel, Switzerland, by Herzog and de Meuron. And I know a number of you are very familiar with this project also, because this building is actually, there's a series of cutouts that create a high rate of theraserialization. And I happened to use it as one of the 28 case studies in that innovations book I mentioned a few minutes ago. The third one is, the example is the Polytechnic in Split, Croatia by 3L HD architects. It's a research institute for healthcare with some outpatient and inpatient facilities. And the fourth, for positive outdoor space, is the example is the Palo Alto Medical Foundation by MBBJ. It's in San Carlos, California, in the States. The fifth is for micro landscapes located along narrow wings. That is, the example is the Rikshospitalet, which has won awards from the Academy, I believe, last year. And it's in Oslo, Norway, by Medplan Associates. And the sixth is the Helsingborg Hospital in Sweden by Schmidt, Hammer, Lassen architects, as representing cascading roof terraces with landscape roofs. The seventh, which was one of the ones that she found was empirically linked to the data, is transparent arteries. And the example here is the Meyer Children's Hospital in Florence, Italy, by Anshin and Ellen with CSPE. The eighth is, the example is the Fleury Medicine de Saúde healthcare. It's in Sao Paulo, Brazil, designed by Perkins and Will and associated with, in partnership with a firm located there locally. The ninth, which is also connected, as you see this chart in the lower right corner, is Peter and Paula Frasius Cancer Clinic in Tucson, Arizona by CO Architects. The 10th is the John Muir Health Medical Center in Walnut Creek campus by Radcliffe Architects in the States. The 11th, called Sequestered Gardens, the example is PUAT Hospital in Singapore by RMJM. And the 12th and final design consideration, which was linked, one of the five that's linked to the empirical data, is the Owensboro Health Regional Hospital in Owensboro, Kentucky by HGA partnership. So what this all means is that that it's an example. I mean, we talk a lot in theory, but there have been too few empirical investigations that put our theories to the test. And we have in this investigation, I know it's only one, it's a beginning, and they need to be more, but it's an example of how, when we talk about salutogenic design that's evidence-based or research-based, it really needs to be researched and not just talked about and not just presented in marketing presentations from firms, but actually rigorously examined. And the university is probably the best place to do that. And so the other point to make in all this, I know I have less time than I was originally given, but we need to blur the lines between, and this work helps to make the case to blur the lines between landscape architecture and architecture the way it's taught in universities. Because often these departments are far apart from one another. They have separate administrative bureaucracies. I'm fortunate at the University of Toronto that we have a unified structure. We don't have a department of landscape architecture or a department of architecture or urban design. They're all in the same building, but they're just called programs. And so we don't have much bureaucracy, and we have a lot of freedom to have interdisciplinary studio courses. And so this fall, for the first time, I'm going to teach a design studio that's 50% landscape students and 50% architecture students. And we're going to be studying behavioral health architecture, psychiatric architecture from this perspective. And I'm really looking forward to that very much. And I think needs to be the trend of the future, is where we blur the lines and we have students studying together from these different disciplines so we don't continue to talk across these disciplinary or ivory tower barriers. Now, there's one other thing that I wanted to mention. I don't know if you saw this article in the South China Morning Post. I saw this the other afternoon. It's called "For Hospitals, Bigger May Not Be Better." And it really summarizes the whole conference and what we're fighting against. And I don't know, how much more time do I have? 5 minutes? 2 more minutes? Well, I was going to quote from it, but the gist of it is that the largest hospital in the world is in Shenzhou in Henan province. It's the biggest in the world with 700 beds, and they're going to expand it more. 7,000 beds, which to me is completely crazy. And we've got to do something about this. And I'm not talking about being a Western colonialist, doing neo-colonialism. We're talking about common sense, about finding other ways to break down the scale. This is something I fought against in the first book I published in 2000, in Healthcare Architecture in an Age of Radical Transformation, it was called. And I railed against something called a mega hospital. And it's a history of healthcare architecture from 1965 to 2000. And I went on and on about these mega hospitals, especially the ones that were built in England, these brutalist hospitals, and the ones in Canada like McMaster's. And here in China, they have the largest in the world. And these are mega hospitals, and they're inhumane inherently, I believe. And what can we do as architects and as landscape architects, and if we can't break the scale down? And so they're talking about, from this top-down bureaucracy, they talk about the need to continue to expand these hospitals because more and more of the population on the mainland is going to the cities for hospital care because they believe that they're going to get better care if they go to the large urban hospitals, and that the rural hospitals are somehow inferior. That's the gist of the article. And so what do the administrators at the large urban hospitals do? They can't forcibly tell people to go back to the smaller, more rural provinces for care because they're coming to the cities. And so they're stuck with a dilemma. What do you do with more patients? And they can't even staff these wards that they're adding because they're having a hard time finding nurses and doctors and qualified specialists to staff these new hospitals that are too big to begin with and are becoming even bigger. So I think that's one of the key challenges that we have to address in this conference. I guess with that I'll stop. Thank you.